directed medical therapy, although urgent patients are usually optimized post-revascularization. The study in a subset of Stage 3C patients with scans performed prior to and 1 year following revascularization. This is being done in randomized patients and as part of a registry. I have described Stage 3C. I want to also introduce the Stage 3 collaborative. There are other harmonized studies testing the same research question funded by separate national funding agencies, which together are considered the Stage 3 collaborative. In the end, we will merge individual patient data to address the mortality hypothesis. To date, funding has been secured from Danish, Swedish, Canadian, French, Dutch, and UK applications. Funding was unsuccessful in the US and Germany, although there are US and German sites involved in the Canadian trial. Australia and New Zealand have an application under review. Recruitment has started in Sweden, Denmark, France, UK, and Canada. The Canadian trial has enrolled the most patients, approximately 100. I quickly review ideas involved. It was an instrumental country stitch. Say that the stitch is pictured in the middle panel. We do have one site open in India so far, Chandra's site. We've been introduced in the Chandrashekhar by Prabhakargan to Raj, and will hopefully be expanding further into India. So to conclude, CABG is the preferred approach in this population. PCI is reasonable, particularly in patients at higher surgical risk. There is no high-quality data comparing the two revascularization modalities in these patients. A large RCT is necessary to address this evidence gap. Thank you for your attention, and again, thank you for the organizers for me to present.
Thank you, Dr. Stephen Fremes. Next, we have a panel discussion. The topic is how to individualize the treatment options in ischemic cardiomyopathy. We invite Dr. Kiran Gopal to initiate the panel discussion. Professor Lorenzo Menicanti, Dr. Stephen Fremes, and Dr. Anil Jain will join online.
I'd also like to thank both our international faculty, Dr. Menicanti and Dr. Fremes, for joining us. We apologize, Dr. Fremes, for the bad audio. So, jumping right in. So, since we had three topics we discussed, one was myocardial viability, the second was ischemic MR, and the third was surgical ventricular restoration. And we'll try to add somehow GDMT and devices will help in the management of these three subset of patients. What I'll try to do is discuss each one, 10 minutes for each one. I have a few case scenarios and I'll ask a few questions, and hopefully we'll have time for some audience questions as well. Coming to myocardial viability, whether improvement in LV function as predicted by pre-procedure viability tests results in improved survival. That is our hope. But unfortunately, all the studies have shown that so far the randomized studies, the STITCH trial and the Power 2 study, which Dr. Anuburu mentioned, did not show any advantage of the viability study. But still, we always want something to clutch on to before we operate on these patients with severe LV dysfunction. So let's look at a case. We had a 55-year-old male who had an inferior wall MI back in 2018. An angiogram done at that time showed triple vessel disease with mild LV dysfunction. It was an advised CABG, but he was not keen for surgery at that time. He presented last year in April with acute onset dyspnea and presented as an ACS STEMI. ECG at that time showed significant ischemia in all three walls. And the echo showed that the LV function had dropped to 20%. There was a severe entire inferior wall, infralateral wall was akinetic, thinned, and hyperechoic. All other segments appeared hypokinetic, and there was so severe LV dysfunction, mild MR, and no PH. The echo images showing the severe inferior wall akinesia and global LV dysfunction. And the estimated ejection fraction was around 20%. Coming to the angiogram, you can see significant triple vessel disease, but pretty reasonable targets. And the right side was, as expected, completely occluded, but was being collateralized from the left. And this is the MR images, which is showing the significant thinning in the inferior wall, with the LG showing significant scar in the inferior wall. The cardiac MRI was reported as an ejection fraction of 15%, with the 5 by 5 segments of the RCA being non-viable, 1 out of 5 in the L6 being non-viable, and the rest of the segments reported as viable. So we'll start off with the surgical surgeon's view. Dr. Anbirsu, with this background, what would you do? What would be your plan?
The EF is
15
20%,
to 20%.
15 to 20%. Inferior wall is completely non-viable. Anyhow, there's not a good target there. There is good viability in the LAD territory, and there is reasonably good viability in the L6 territory. And how old is the patient, you said, Kiran?
For 50, I think 50, 45 to 50 years.
Okay. I think he would benefit from revascularization. There's a good LAD, there's a reasonably good diagonal, and a good obtuse marginal. I think 3 good grafts.
Yeah.
It is a high-risk surgery, but he should improve with surgery.
So since we are lucky to have three of our very well known, very good clinical cardiologists, all 3 of them are very good academic cardiologists as well, so we can get their perspective as well. So and as an initial assessment for viability, what do you think of Echo as a standalone assessment of viability? Dr. Hisham, if you can take this question.
Yeah, I think, especially in this context, I think in this case, I think the echo that you showed, I think the inferior wall is very markedly thinned, akinetic, and it's thinned out and very hyperechogenic. So in terms of echocardiography, when the wall thickness is generally less than 6 millimeters, and when it's akinetic like this and thinned out segment, and there is hyperechogenicity, there is a very high likelihood that those segments are non-viable. So I think in terms, of course, it's not telling us anything about the metabolic viability in that sense, but in terms of the initial impression from the echocardiogram in this particular patient, all of these features, a very thin wall, akinesia, hyperechogenic and thinned out, one would have to assume that those segments are clearly non-viable.
So is there anything on the echo? I mean, would you like say, this echo is enough, I don't need any further viability assessment, I'm happy with this?
In this particular patient, I think the echo images are quite convincing. On the other hand, I think if you see that the walls are not entirely thinned out, like in this patient, and if it's not entirely hyperechogenic or thinned out, as in this patient, then yes, I would choose another modality. The preferred modality at our center is, of course, cardiac MRI, where it offers enough structural information with very good resolution to assess myocardial viability, yes.
So just to the next modality, Dr. Anuburu had mentioned sensitivity, specificity of all the modalities, and we see that the dobutamine stress echo is ideally the most specific modality, but we don't use it much in clinical practice. Dr. Natarajan, an opinion on why we do not use dobutamine stress commonly?
As is already mentioned, the preferred modality in our institution at least is cardiac MRI. Dobutamine stress echo is more time consuming, and it is more for inducible ischemia in terms of at low dose dobutamine obviously for viability, high dose is for picking up ischemic territory. Hisham may be better than me to answer the question as to why we are not routinely using DSE and why we are preferring cardiac MRI in terms of assessment of viability.
Yes, I think if you look at most of the data sets which have come through published literature, I think we are I think we are quite categorically moving towards CMR in terms of viability assessment. The sensitivity is pretty bad for dobutamine stress. The specificity is quite high, but then for these patients to sort of to adjust the dobutamine dosage so that they acquire or they reach a target heart rate, these are sick patients, and all of this in combination with the fact that it's a low sensitive investigation, and on the other side you have a procedure which is fairly quick, relatively quick. The risks are less compared to a dobutamine stress echo. The sensitivity and specificity are quite high, and it gives you information regarding clear structural information with extremely good resolution. And late gadolinium gives you an assessment of the scar burden and viability as a whole. So I think as a combination of all of these factors, and I think CMR has actually superseded dopamine stress echo. We have not, as Dr. Natarajan has said, I can't even remember the last time that we did a dopamine stress echo for cardiac viability.
But what about PET? I mean, that's a question that is coming next.
The next question was further evaluation. Which patients go for PET, which patients go for MRI? Is there some guideline for that?
So I think we'd have to go to the PAR-2 trial for the PET viability. So I think the general ballpark figure is that if you do a PET, I mean, in terms of PET versus the technetium viability at least. So approximately another 10 to 15% of patients are categorized as having viable myocardium when they have a PET study as compared to the conventional nuclear scan. In terms of a PET versus MRI, I think the data is more in favor of getting an MRI done because, again, the structural resolution is far greater with MRI. MRI not only gives you structural information as in terms of wall thickening, it gives you information regarding aneurysm, it gives you information regarding microvascular obstruction, which is again a surrogate for non-viability, and of course LV apical clots, and of course it gives you a comprehensive assessment of viability. So when you have one tool which can provide all of this information, structural information as well as information regarding viability, I think this would be the preferred imaging modality.
Just to round it out, Dr. Jabir,
Only one word of caution I will say is we do not have an expert in nuclear medicine in this panel. And recently we had one online session. I don't know whether you logged in. There was somebody from, I think from Canada, that lady.
Canada.
She was vehemently in support of PET as an important tool in assessing viability as well as ischemia. So in our center, we have a preference for MRI. Probably PET will be a close nucleus. The SPECT is no longer the gold standard. PET, of course, should be kept in mind. We don't have access to the PET nutraceuticals in the Indian context now. Yeah.
Sorry? Dr. Fremes, what do you think about MRI versus PET in the assessment of viability?
Well, our preference is CMR, although in Canada there's little access to PET for chest imaging. So some of the expertise was in Ottawa, and maybe the person that you were speaking to was from Ottawa. That was the lead investigator of PAR. On the other hand, CMR is pretty readily available. So part of it is access. As far as if we had to pick one tool, it would be CMR. We usually use PET more, not for viability, but for situations where there's IE and concern about the extent of infection. But that's a much different situation.
Okay. Dr. Jabir, ECG, any role for evaluation of non-viable?
If you truly speak science, absolutely unreliable regarding viable myocardium. But for a practical purpose, a Q wave, broad QRS, notched QRS, if and the echo showing that particular area having a scarred or a thinned hyperechoic myocardium, we can reasonably conclude that this is likely to be non-viable, but the specificity is low and we have better tools.
So this patient subsequently underwent an off-pump CABG, uneventful recovery, and 3 months follow-up. His EF has improved to 35%. So, Dr. Natarajan, at this stage, would you consider an AICD?
No, before that answering that question, most of the trials which have addressed the issue of revascularization in the context of ischemic cardiomyopathy, viability, no viability, all that put together, it's only a modest about 5%. It's not that 15% will become 60%. So it's a substantial recovery of ejection fraction in this particular case. As how many months? This is 3 months.
3 months follow-up.
3 months follow-up, ejection fraction improved to 35%, going by the guidelines. He is a candidate for an ICD implantation because we have crossed that magic number of 90 days. As I told in the presentation, 40 days after myocardial infarction, 90 days after revascularization is the time to assess the impact of revasc on the LV function. If the LV function continues to be persistently lower than 35, you have given a little troublesome figure of exactly 35%. 35 or less than 35% becomes an indication for primary prophylaxis ICD implantation, particularly considering the patient's age of only 50 years.
50 years.
Raj, I would like to ask you one more thing. It is exactly 35%. And if you go for another observer who is, or another echocardiographer, it will be 37%. So would you like to do a cardiac MR and see what exactly is the LVF? Or is it important? How important is it?
All the
Or go
trials.
for aggressive medical therapy, all medical therapies, all 4 pillars on therapy on board at the maximal tolerated dose and reevaluate.
No, we were actually briefly discussing this point. Most of the ICD trials were done at a time when we did not have these 4 pillars. Maybe beta blockers were there, MRIs were there, SGLT2 inhibition and ARNI was not there at the time when most of these ICD trials were done. So we now have data that with contemporary advances in pharmacological treatment, whether the same results can be extrapolated to contemporary times, the answer is no. But there is not going to be any trial which is funded by the device industry will randomize now with contemporary medical treatment. So we only have to go by historical data. Dr. Jabir has a very valid point that you don't have to jump and put an ICD. We have to go by the figure of less than or equal to 35% going by guidelines. That's all we have. We can only go by what we have. But as he rightly said, probably the risk of sudden cardiac death with an EF of 35% is not as high as it was before the era of ARNI and SGLT2 inhibition.
We just pivot now. You just imagine if we had the same patient presented with the same symptom, but his MRI now showing, instead of inferior wall, shows a thinned out anterior wall apical out part, and the LG shows scar in the anterior wall. And the MRI is reported as 5/7 out of the LAD territory is now non-viable. Ejection fraction is 20%. So as a surgeon, would you offer surgery, Dr. Jaykumar? Would you offer surgery to this patient?
Yeah, actually, the angiogram is the same.
Yeah,
That's what
let's
you're saying.
presume angiogram is the same.
Yeah, good targets, and the LAD territory is the aneurysmal. So we can go for a restoration plus revascularization. That's something which we can do.
Even if the LAD is non-viable. Suppose there's no aneurysms, it's just a non-viable LAD.
Then
Territory.
I may not. Actually, it is little controversial, but still, I totally non-viable LAD. I don't go ahead.
Dr. Menicanti, what would be your approach? Suppose the patient does not have an LV aneurysm, non-viable LAD territory, severe LV dysfunction.
But you see, we are speaking about bad function of the left ventricle, but no one's said about volumes. And the volumes of the ventricle, we know, is the first risk factor for mortality after an acute myocardial infarction. And this is the reason for what, when we speak about viability in the stitch trial that didn't demonstrate any advantage according with viability or not, if you look the data of the stitch trial, the patients that are with favorable outcome, in spite of the fact they have viability or not, are the patients with smaller ventricle. And this is the key to understand the problem. So if you compare two different coronary situations, but you don't verify the volume of the ventricle, you are completely confusing. Because if you have the ventricle that is not so big with 3 vessels, this patient probably after the procedure is increased ejection fraction. In the opposite, if you have the same coronary situation, but the ventricle is big. Big, that means more than 90 and systolic volume index milliliters. This ventricle, in spite of the fact that you revascularize, in spite of the fact it can have some viability, it doesn't improve the ejection fraction. This was demonstrated long time ago. So to go back to this patient that you show us now, for what I see, I see a patient that he got acute anterior myocardial infarction with a dilatation of the apex, and I have not seen the magnetic resonance, but I think that there is a scar in that situation. So probably this is the patient that need to be a complete revascularization and a restoration of the left ventricle if the scar is present. So if the magnetic resonance show us that there is a scar on the apex of the ventricle. In this way, you reduce the volume and you increase the life expectancy of your patients. As I show you in my presentation, we compare our result with the stitch trials, and the volume that we achieve with surgical ventricular restoration, there were volumes that are lower than in the stitch trial. And this is the reason for what in our group, the patient, the life expectancy, the outcome was much better. So I think that the trick is that one. So in my idea, according with all experience and all the data, all patients must be revascularized, because this is very important, because it's very difficult to know exactly the viability. If you have a very dilated ventricle, viability does mean nothing, because the wall stress is very high. So I think that anatomy is really very important, and the volume of the ventricle, it's the key to understand which kind of the patient can improve or not.
Okay.
To clarify what he just mentioned, without a so-called localized aneurysm, a globally dilated LV with high systolic volumes, according to him, is a candidate for SPR. It is not just dyskinetic apex or something like that. Non-viable LAD territory, old MI, globally dilated with gross increased volumes, the way it is shown here, he still says is a case for considering SPR.
Dr. Bana, what would be your grafting strategy? Would you use the IMA in this particular patient, non-viable LAD territory?
I think IMA, I don't think so. IMA has much of a use, but definitely vein graft will do the same thing. And because we don't see them living for a very long time, despite you do a ventricular restoration or maybe revascularization, so the life expectancy is not that good. So better not to put a IMA. But if a younger patient and surgeon is comfortable, LAD is very good, as in this patient, may put a IMA, but not very much advantage, I see.
So I have another doubt, Kiran. Like in this
May
case,
I see one thing? May I see one thing? When we see that the anterior wall is akinetic, is not viable, but we know that the left anterior descending is occluded, the fact to do a graft on the left anterior descending, it's, I know, some blind procedures, but very often there is some septal branches that are still working. And in that case, the upper part of the septum must be protected. So this is the reason for what, when we do this type of procedures, we do always a graft in the left anterior descending. And we know that often that can be not useful, but surely is not harmful.
Fair enough.
yeah, if you look at if the revascularization of the LAD territory is not very useful, means it's all scarred or non-viable. That means, is it okay to go ahead with the PCI rather than a high-risk CABG. So
I'm very happy that the surgeon is asking the question. If the LV is not very dilated the way the international faculty said, and if the circumflex and right coronary artery are eminently suitable for an angioplasty, we can always consider that option. LED territory is non-viable. The LV is not globally dilated because he has been a proponent of SPR in a non-viable LV with grossly increased volumes. If that is not the case, the Indian practice will be with the less experience in SPR and not very many centers which are comfortable doing so on a routine basis. I think a reasonable option will be to do a PCI to the other vessels if it is possible. And of course, definitely we'll consider an ICD in that case for primary prevention.
So we'll just move on. For lack of time, we'll move on to ischemic MR. Arguably, probably the worst disease among the three because survival declines steeply as the MR severity increases and not great outcomes overall, as described by Dr. Bana. So coming to a patient, 57-year-old male, breathlessness class 2 into 3 weeks with some chest heaviness, vital stable, no obvious murmur, labs were normal. This is his angiogram showing a tight lesion in the proximal RCA, diffuse disease in the LAD, and diffuse disease multiple blocks in the circumflex territory. So his echo, again showing some inferior wall, inferior lateral wall, hypokinesia and scarring, and then an eccentric posterior wall hugging jet. So we're looking more or less like ischemic MR, but the quantification was moderate at best, moderate to severe at best. So we already had a discussion about severe ischemic MR, but what do you do if your patient has moderate MR coming for CABG? Dr. Anil Jain, moderate ischemic MR coming for CABG.
Yes, I have been a very aggressive surgeon for correction of mitral regurgitation. And there are many parameters that I consider before I decide whether to repair or not. If the left ventricle has good myocardium on the inferolateral wall, if the LV is not too dilated, then in those patients, revascularization alone may answer the problem of regurgitation. But in patients who have had history of inferolateral MI, where the LV lateral wall is dilated, where the tenting is significant as can be seen in this patient, even if they're moderate to severe MR, I prefer to address this. It doesn't take more than 30 minutes to correct the mitral regurgitation. But the long term, what we have seen is when they come in follow up, if the inferolateral wall is infarcted, it is not good, then there is a chance that the mitral regurgitation may worsen. So in these patients where there is inferolateral wall infarctions, less viability, less benefit with revascularization, then in all these patients, we go in and do a mitral valve annuloplasty. Many a times, we even put, if required, an L-ferry at the level of A3-P3 to prevent recurrence of mitral regurgitation when the inferolateral wall, possibly because of a previous MI, can dilate. So we are aggressive and we've been regularly correcting more than moderate mitral regurgitation in patients with ischemic mitral regurgitation, where the lateral wall is definitely infarcted and scar related.
Dr. Fremes, what would you say for moderate ischemic MR coming for cabbage?
Yeah, great question and a really difficult clinical problem. I agree that revascularization is the key, and I agree with Dr. Jain about the viability of the lateral wall or infralateral wall being important. We're typically more conservative with the mitral valve if it's moderate, and part of the reasoning is that there is a MitraClip option often in the future if the MR persists or gets worse. The other thing is that our experience with annuloplasty alone for moderate MR is not good, with a moderate relapse rate. However, if it's severe, we usually replace. So I would say for moderate, we revascularize, and if it progresses or worse, there is likely a mitral clip option. We'll ensure that there is one before we operate.
Okay. So
Just on to moderately severe MR and partially viable myocardium, revascularization and the trials before that, ARNIs was not there, SGL2 inhibitors were not there. So these drugs have come in. Probably they are going to change the scenario. So moderate and moderately severe MR, revascularization and medical therapy. Okay.
So, cardiology perspective, patient with moderate ischemic MR, Dr. Hisham, anything on the echo which you would like, will be like a red flag which you would tell the surgeon, I think this person's MR is not going to go away after revascularization, even though it's moderate, I want you to address it.
No, if there's an obviously tethered, you know, posterior mitral leaflet, I think if it's a large scarred inferolateral wall with clear tethering of the, you know, PML causing severe MR, or let's say moderate MR, and there's a clear structural substrate there and identified on the echo, and we know that that's very unlikely to recover despite revascularization by surgery. I think that's, I mean, a clear structural substrate like that would perhaps be an indicator to communicate to the surgeon that yes, I think this is something that, you know, it would be better off maybe to take care of during the surgery. Yes.
Dr. Jaykumar, moderate ischemic MR, what would be your treatment? Mitral repair or replacement, if at all you decide to do an intervention?
No, yeah. Moderate ischemic MR of this sort, I would go for a repair, because if you have a very dilated left ventricle or the interpapillary distance is high, or if the tethering height is more or the tethering area is more, this is a subset which is not good for a repair. But otherwise, this can be repaired. Only thing, so far, just putting an annuloplasty ring may not be sufficient. I usually add some subvalvular procedures like papillary muscle resuspension or a PML enlargement. So to address the real pathology, that would be my approach. Yeah.
Then Dr. Jabir, like the question Dr. Bana asked, with so much improvement in GDMT and CRT device, has it changed your practice in referring patients for ischemic mitral valve repair, ischemic MR repair?
We can have a reasonable trial for the guideline recommended medical therapy. If the LV size comes down, the volumes comes down, the MR may come down. We can give it, because this MR is a moderate MR, how much it contributes to the symptom of the patient and also the progression of the further deterioration of the LV function. If it is not producing further deterioration of the LV function, and with the guideline recommended medical therapy, because most of the current guideline recommended medical therapy, including ARNI, especially ARNI, has shown that there can be a decrease in the mitral regurgitation, especially due to the increase in the annular size when the LV size regresses. So we can give a reasonable period of time, provided the patient is not symptomatically deteriorating. And after that, if it is not improving and there is a definite structural substrate for repair which is going to help the patient, I will not continue, I will not fully rely on guideline recommended medical therapy.
Because of lack of time, we just skip the mitral clip. So coming to LV restoration, like Dr. Menicanti mentioned, it's done for patients with severe LV dysfunction, significant heart failure symptoms, and a badly remodeled LV involving the anterior wall. And Dr. Menicanti already described all the trials associated with LV restoration, and it will be beneficial in the right patient with the right indications at a center with the necessary experience. So coming to surgeon perspective, I think Dr. Nair, you could if you could tell us what do you use as your criteria to do a surgical ventricular restoration?
I've been a follower of Dr. Menicanti for many years, and that's why I am a great proponent of doing an SVR whenever indicated. I think, as he mentioned, the size of the ventricle is very important. Ejection fraction, of course, anterior wall involvement in a full thickness myocardial infarction. So if I see starting with a patient, starting with the ejection fraction of less than 35%, a poor ECG is very important to me, Q waves or a poor progression of the R wave. And then I usually get a viability assessment done, either CMR or a technetium scan, which is available in the institute where I work. And then I would go ahead and do an SVR for sure. My technique is not entirely always what Dr. Menicanti described. I do most of my cases using a small patch with a Fontan stitch, which was as per the original description. But in some cases, I have been using the double horseshoe pledgeted stitch, which is described by Ferazi. So both these techniques are what I usually use, but I definitely believe that patients do far better. I have never regretted doing an SVR in patients with severe LV dysfunction and multivessel coronary artery disease. I always graft as many vessels as I can to preserve the remaining myocardium. And I also put Lima to LAD because I think Dr. Menicanti many years ago published data show that Lima to LAD is helpful for these patients in the long term.
Dr. Menicanti, if we could just, clarify what you presented, is that you never use a patch anymore to reconstruct, irrespective of the size of the defect? Is it always direct suture repair?
You are right, because of course in the beginning we used a patch in every patient. But after that, I show in the slide, if you follow the transitional zone, also with Fontan stitch, and you put a patch over there, there is the possibility that you reduce too much the longitudinal diameter. That means that at the end you have a smaller ventricle, but you increase the sphericalization of the cavity. That is not good because that increases the diastolic dysfunctions. So by the time you realize that if you keep a sizer inside that allow you to respect the longitudinal diameters, in some cases, as I show in the movie, there is a gap between the transitional zone and the new side of the apex that is indicated by the apex of the balloon. So we reduce the inferior dilatation and we pull up the new apex. At this time, it's very easy because if you have a sizer inside, you close over the sizer the ventriculotomy. In this way, you are sure you are respect the longitudinal diameter and you respect the volume because you have a sizer inside. In this way, the possibility to have a sphericalization is really very, very low, and the result is better. Also for the function of the mitral valve, because the mitral valve, if it's a spherical one, the base of the papillary muscle are displaced. If you achieve a more ellipsoidal shape, in this way, the papillary muscle are in more physiological position. And this avoid that in the follow-up can rise some mitral regurgitation. So now I think that are more or less 7-8 years that we don't use more patches. And we have to say also one thing, that the patient that we treat now are not a classical left ventricle aneurysm and are more similar to dilated cardiomyopathy after anterior and septal infarction. So the way to try to rebuild the inferior wall is bring you in a situation more physiological, and the results are really good.
Kiran?
But of course, you must know exactly the characterization of the wall, and for this reason, I think that magnetic resonance is really very, very important.
Lorenzo and Steve, thanks for joining us here, and Lorenzo, I enjoyed your talk.
Hey, Chanda, ciao.
Ciao. And hi, Steve. So I have a question for you, Lorenzo. I think after you showed us how to do this without the patch, last few cases we have done like that, the same plication. But most of these are chronic aneurysms with thick tissue. So when you go in early for an aneurysm, is it the same way you can do that? These tissues hold on to this because this stress on the native tissue is quite high. Is there situations where you still use a patch when you have to go in early, or how early or how late you delay for this procedure?
This is a really very good question. The first one is that when you touch ventricle with old left ventricle aneurysm, you have a very clear definition from the very good basal portion and dilatation. In these cases, sometimes you need a patch because it's difficult to close over the balloon, the cavity. So in these cases, is the patch, of course, can be used. Pay attention that is not parallel to the mitral valve. When the myocardial infarction is a relative recent, or you see a not clear demarcation from the transitional zone and dilatation of the ventricle, in these cases, to try to have a good ellipsoid with plication inferior wall and closing over the balloon, it's easier and is guiding you, because in this particular case, the scar it's not so clear and the definition not so evident. So in this way, to avoid the patch, in my idea, it's a good idea.
Thank you.
This is one question for you, Lorenzo. If the linear closure is many times possible in anterior or inferior, if the aneurysm or pseudoaneurysm is close to the mitral annulus in the posterior wall, is it better to do a patch, or it is linear, will affect the mitral wall as well? Linear closure.
This is a very, very good question. I think that in these cases, when there is a inferior dilatation, inferior aneurysm that is start from the annulus of the mitral valve and they go around, normally it's arrive at the base of the papillary muscle. I think that the linear closure in this case it's really very, very good, because there is no a lack of tissue, but there is a small tissue that's become big. So in this way, I think that a double running suture, a linear running suture that starts from the annulus of the mitral valve to the base of the papillary muscle, it's very, very effective. And from this approach, you can also reduce the annulus of the mitral valve, because sometimes it's bigger, and so you can fix the mitral insufficiency. So in the posterior dilatation, I think that linear suture is the best way to treat.
I have one question. If the patient is having 20% EF with globally dilated LV, and on viability testing there is a scar in all the three territories, still we will go for aneurysm repair or the reduction of the LV size, or should that patient, if the facility is available, referred for transplantation? Dr. Menicanti.
You are absolutely right. Of course, when we have patients like that with globally, and we have not a clear basal portion that it's working, the first thing that we check is the right ventricle. If the right ventricle is failing also because all the septum is gone, this is a clear contraindication of these procedures, and the patient go to the heart transplant. If the right ventricle is good one, and the basal portion is working also, we know that in this particular case the surgical risk is really very high, particularly if there is pulmonary hypertension and mitral regurgitation. In these cases, it's depend of the patient, of course. If you have a young patient, you have a good possibility to have transplanted, so this is the way. But in the other way, if the patient is old or you have some comorbidity, there is no other choice. And at that time, we speak clearly with the patient and the family, and we decide together if go to the surgery. It's evident that in a patient like that, the mortality that we had, it's around 16%. In the other patient, we had 3% of mortality. So, of course, it should be trimmed according to the type of the patient. But generally speaking, when you have a global dilatation without a clear portion of the ventricle that it's working, this patient, if there is a dysfunction of the right ventricle, is contraindicated to do these procedures.
Thank you.
Any
I
other
can,
questions?
I can add to that answer. I think the patient should be considered for advanced therapy selectively in a center that does provide advanced therapies. But if the patient has a global LV enlargement, but without AV valve involvement, like no MR, no TR, no pulmonary hypertension, a good RV, patient probably will do well with revascularization alone. On the other hand, if there are more advanced findings of ischemic cardiomyopathy, specifically MR, TR, pulmonary hypertension, and RV, then that is certainly a patient who's unlikely to do well with revascularization alone. If the patient's had a long trial of medical therapy, perhaps they will convert from someone with bad biventricular function to someone with a better LV and lessening of MR, TR, and pulmonary pressures and RV, and that patient may be suitable. But I definitely agree that in some patients they should be considered for advanced therapies.
Any other questions? So we'll close the session then. I'd like to thank both our international faculty, Dr. Menicanti, Dr. Fremes, and Dr. Anil Jain for joining us, and all our panelists. Thank you.
Thank you, speakers and chairperson, for the excellent discussion. We now move on to the much anticipated SCS oration. We invite Dr. Chandrashekhar Padmanabhan, President of SCS, and Dr. Sanjit Peter, Secretary of SCS, to chair the session. It gives us great pleasure to invite Professor Torsten Doenst to deliver the SCS oration. The topic for the oration is challenging the revascularization paradigm. We would like to invite Dr. Praveen Varma to introduce Professor Torsten Doenst.
It's a great pleasure, honor, and privilege to introduce Professor Torsten Doenst. He is currently the chairperson and chairman of Department of Cardiovascular and Thoracic Surgery at the University of Jena. He has published 787 articles and has a citation of more than 17,000 with an H index close to 70. If you look at all the guidelines, ESC, ESCTS guidelines, he is a member of that society. He is a member of the guidelines for infective endocarditis, myocardial revascularization. So the Society of Coronary Surgery welcomes you to give the first SCS oration. Thank you.
Thank you. Thank you, Praveen, and thank you, Chairman and ladies and gentlemen. It is a great pleasure, and it's a true honor to be able to speak here. And this reminds me of something that Denton Cooley said when we were in Texas at Texas Heart Institute learning how to implant an assist device many years ago. And but Fraser was there, and we had lunch, and Denton Cooley comes by. And so he's talking to us, and then Cooley says, who was the first man? We were just shooting the breeze, and he said, so who was the first man who flew across the Atlantic? And everybody said, Charles Lindbergh. And then Cooley says, who was the second? And nobody knew. And so he said, well, see, I told you, it's always good to be first. So I'm the first, obviously, to do this. So thank you very much for the invitation. And thank you for the opportunity to present some of our thoughts here. And just, I've learned so much about India and you, so I thought maybe I'll tell you a little bit of where I actually come from. Jena is the home of Carl Zeiss, and it's the science city, and we are a regular university size. We have 1,400 beds, but we have different departments and so on and so forth. But I think the most important thing for you to know where it is in Germany is right here, and you know Leipzig, you know Berlin, you know Munich maybe, and Frankfurt. So Jena is close to Weimar, and Weimar is a smaller city even, but that's the home or the beginning of our first German democracy in 1920 or 1920, yeah, in the 1920s, and that didn't last too long, unfortunately. But that's where Jena is. So with that, I would like to go on that I don't have any conflicts of interest, except that I believe that knowing facts and mechanisms improves patient care. And because of that, I have done with my team in Jena reviews for the cardiac surgical literature here for the past 11 years, more or less. And so if you are interested in reading what sort of is the key, at least in our opinion, you're more than welcome to download our most recent one where we just basically summarize this. And I will always call it cardiology bedtime lecture, because the bedtime reading, because the cardiologists obviously don't spend time in reading the surgical literature. Why should they? So this is sort of one piece that they may read in order to understand what's going on with us. And of course, we cover the connections. All right, so we also have a podcast here with one of my surgeons who's doing this. So we're very much busy in trying to bring out the information to the world, because that is important. So now I want to get into the topic from today. And I know you've had a hard, almost, 10 hours already of constant lecturing, and it'll be difficult for you to follow maybe, but if you can stay awake for the next few minutes, and if you will be able to listen to this, this is going to either confuse you or change your world. Okay, so let's systematically address this paradigm, and you've heard Steve Fremes use the word revascularization at least 10 times. And I keep telling him there's a problem with that, and you will know after this talk what the problem is, okay? So what is a paradigm? A paradigm is an overall concept accepted by most people in science because of its effectiveness in explaining a complex process, idea, or set of data, okay? So, what is the revascularization paradigm? And I would like to ask you to disagree if you don't think that is what I say is right, okay? So we summarize revascularization, PCI and CABG under the term revascularization. Everybody agrees, okay. We believe that revascularization treats ischemic symptoms, angina pectoris. I think everybody agrees. I think we believe that ischemia, that revascularization improves contractile function if it is impaired. You just talked about it, just in the last session. And we believe that it prevents myocardial infarctions, and it eventually is supposed to prolong life, correct? All right, so we all agree. There's nobody that disagrees. So let's examine what this situation is like. So first of all, what do we do? I told you before, the new guidelines don't give specifics anymore. So if we look at the old one, there is here, we look for the type of revascularization and coronary artery disease that is suitable for what we do. So we are looking for obstructive disease. Okay? That's number one. So we select the patients that we want to treat because we can treat them. We don't necessarily treat coronary artery disease in general. Number one.
Okay, so what mechanisms do we use in order to do this, to do our thing? So I believe that if we have inducible ischemia here, at rest there is no ischemia because flow is enough. That's why you have to induce it in order to detect it. Okay? So if you have an MRI or a stress test of some sort, and they tell you 20% of the heart are ischemic, does that mean that the heart is ischemic right now? Or does that mean that the patient has to walk up the stairs in order to get this ischemia? I believe the latter. And I believe that inducible ischemia is this. You have normal flow at rest, sufficient flow at rest, and once you stress it, then all of a sudden there's a problem. So if you have inducible ischemia, the mechanism of treatment can be restoring coronary flow capability. So you have more flow when you need it, but you don't need it right now. Okay? Okay. Then there is the situation where we have ongoing ischemia, acute ischemia. That's here. And then that's the classic situation where you have infarction, a vessel occlusion. Then you need to revascularize, right? But what's the mechanism? The mechanism is reperfusion, and we all know this, ischemia, reperfusion. Clear thing. Now the question is there something like chronic ischemia, hibernation? Big discussion whether there is actually limited flow. There's acute ischemia ongoing in this situation. Chronic ischemia is a term that cannot be really defined. Hibernation is not really clear whether the flow is really too low, but it may be that it actually matches what is needed, and then there is no acute ischemia again, even with chronic ischemia. So the term is, and then there, of course, there is a risk of infarction because you have a plaque that may rupture at any time, but it's not flow limiting, it's not the problem at all. So that is your mechanism that you may exploit here is you prevent an infarction in the future, but that doesn't necessarily have to do with flow right now. Okay? You're all with it. Okay, so now we keep going. So this is a video I have. So if you have a patient, you can show him. Normal flow through a vessel, you have a coronary lesion that is forming here. That lesion that is forming gets more and more and more. It becomes obstructive, it causes symptoms, it occludes, it causes an obstruction, and it causes myocardial infarction. Okay? So, this mechanism explains this here. These are the occurrence of myocardial infarction. So the fraction of infarctions that are caused by severe lesions where the vessel then occludes is only here 14%. So I believe it's only 10% of the infarctions that we see, that we witness in clinical daily life, we and the cardiologists more so, are not caused by obstructive lesions that are then causing the infarctions, but they are caused, the main mechanism is this here. And they are here, the majority of infarctions come from, hold on. Here it goes. Come from this mechanism. You have a lesion, that lesion doesn't do anything, it doesn't obstruct any flow, it ruptures, and then the plaque is thrombus is forming, and that occludes the vessel, and that's where your infarction comes from. The majority of vessels, infarctions come from this mechanism, okay? So, now the question is, let's go through the different mechanisms of treatment that we have, and the impact of what you expect. So let's say we have inducible ischemia. Does inducible ischemia, revascularization for inducible ischemia, do what we expected from it because of the revascularization paradigm? So there's a trial for it. It's called ischemia trial. Has been massively discussed and has been bombarded by surgeons for, and we've heard it before. Pradeep talked about it, and so, but it holds valuable information. So does an invasive strategy improve the outcome in chronic coronary artery disease if ischemia is detected? They had ischemia in every single patient detected, and then there was an invasive strategy with PCI and CABG and all so on. So, you know this. What did it show? A reduction in symptoms.
So when you walk up the stairs, your angina doesn't show up anymore because your flow capacity is now higher. You can have more flow. You have no inducible ischemia anymore. Does it change your life expectancy? Nope. No difference in mortality in the ischemia trial. Why would you expect it? Because you can decide not to walk up the stairs, right? So you can avoid the ischemia, and that's why. So we can say if we treat inducible ischemia by restoring coronary flow capability, we have symptomatic relief. That's what ischemia has shown. You didn't need the trial for showing this. There were other data that could show the same. So 100 million gone down the drain for nothing, right? Okay, so what about now if revascularization and treating inducible ischemia is a problem? Let's say there is chronic ischemia. Maybe now that's something that we can do in chronic patients because hibernation, poor ejection fraction. Maybe this reperfusion aspect comes into play for patients with poor ventricular function, okay? So stitch trial. So what did the stitch trial show? Yes, there was a survival advantage of cabbage in this case. So how do you explain this? Because you provide more flow, that's it, perfect. But there's a problem with the stitch trial, and you've addressed this already, and you know this. How do you explain that patients without myocardial viability just benefit from cabbage just as much as all the others? That doesn't make sense. You should not revascularize this patient without viability, but it still is an effect that you can witness. Okay? But now, don't worry about stitch, we have Revive, because Revive specifically assessed this. Revive had similar patients, poor ejection fraction, coronary artery disease, and now detected the ischemia, had at least 4 regions, you know all the details. And now you go by PCI, by treating the obstructive lesions, you would think now we have to see the survival advantage, if there is a problem, if that reperfusion mechanism works, right? Okay. What happened? Nothing. Nothing whatsoever. PCI, so revascularizing patients for inducible ischemia, increasing coronary flow capability for inducible ischemia does not improve survival. So the reperfusion mechanism in the chronic setting, you can forget about it, doesn't make sense. So we end up with this inducible ischemia treatment and restoring coronary flow capability as mechanism for the treatment effects, and that's a symptomatic relief. Okay? So maybe, how do you explain the survival advantage then in the stitch? Well, maybe it's through infarction reduction, right? But that was not really assessed in stitch. That's the problem. So we don't have any randomized data for this. But there are all the other trials that compared cabbage and PCI. And if you know, we can assess, and they actually assess the rate of myocardial infarctions at the same time. And you know here, you probably know this meta-analysis from Stuart Head, where he combined all the 11 randomized trials PCI cabbage, except for the FAME trial that came out later, but showed the same. A significant survival advantage of cabbage, again, against PCI. Okay? So that's, again, chronic ischemia. So cabbage improved survival, but so how do we deal with that? Well, this is something we addressed a few years ago in a paper that we published in JACC. And so here's the situation. You see better survival in the cabbage group if you see less myocardial infarctions in the bypass group. Okay? So if you have less myocardial infarctions, I would argue less people also drop dead from a heart attack, because a certain fraction of patients die from a heart attack even today. So that is the suggestion that we have, and that led us to this conception where we said, if you treat a severe lesion here with the bypass, you graft all the other lesions as well. And if something happens there, then nothing happens if there is a bypass on it, but it must be a patent graft. And if you treat the high lesion here, the severe lesion with the stent, there's nothing you do about this, and 90% of your infarctions are this type. So how do you expect to reduce myocardial infarctions with a stent? It cannot be more than 10% reduction, because it's 10% of these lesions only cause about 10% of myocardial infarctions. Okay? So we did this with Mario Gaudino a few years ago. We joined forces and we did this meta-analysis of all the trials comparing PCI and CABG with randomized, non-randomized, whatever. So, and this is the summary here. You see, CABG is better than PCI, yes. But if you separate this into those where in the CABG group there were less spontaneous myocardial infarctions, you have a massive difference. If you have no difference between PCI and CABG in terms of spontaneous myocardial infarctions in the follow-up, you see no difference. Okay? So the bottom line is you have two treatment mechanisms in chronic coronary artery disease. The one is treatment of inducible ischemia that gives you symptomatic relief, and then you have prevention of the risk of infarction, and that improves your survival because the patients that do not get the infarction do not drop dead from it. And that is something where CABG is massively better than PCI if the risk of MI is high, and that's why we need the anatomic complexity. So, not all infarctions are lethal. So, if you have a Nobel trial, we heard about this morning, mortality exactly equal between PCI and CABG, but non-procedural myocardial infarctions, significant difference. These guys had infarctions somewhere, but they didn't kill them. Left main trials, same thing. You have difference, you can argue whether there's a difference in mortality, but there's a massive difference in spontaneous MI. Why? Because the left main has been dealt with, but then the rest, there may be smaller areas where myocardial infarctions occur, maybe they're not that lethal, right? Okay, and syntax, we also heard about this. This is here, high syntax score, significant survival difference, even in the small population. It was never powered for mortality alone. And even in the subgroup, this shows up. So there's a massive price. So I could go on forever. I could say diabetes, or chronic kidney disease. When the patient has a high risk for myocardial infarction, he benefits from CABG. Okay? So now this comes. If you have, this is a registry of patients with left main, where there is medical therapy with left main, high mortality. Now, with CABG, you reduce it, but with PCI, you also reduce it. So how do you explain that? Well, there is a meta-analysis from Stefan Windecker. He published this in the British Medical Journal in 2014, highly controversial network meta-analysis, right? Because he played everybody against each other, and then he came up with these rate ratios. And then he said that some of these stents here actually prolonged life, which is, it's a statistical trick, but he showed these rate ratios for mortality and for myocardial infarction. And here's what happens when you correlate these ratios, the risk for infarction with the risk of dying. This is the thing that you've seen, CABG versus PCI. You've seen that already. But here's all the studies from the Windecker analysis for PCI versus medical therapy. So, a significant correlation. So again, if you have a risk for myocardial infarction and you can reduce that risk, you can reduce mortality. Okay? But the problem is you need much more data and many more patients because the treatment effect for PCI is so much smaller than that for CABG. Okay. And you can even see this here if you look at REVIVE and you look at spontaneous MI, look at this. There's procedural MI, there's spontaneous MI, and here is twice as high in optimal medical therapy. And so the treatment effect is visible, but with the treatment, they induced so many infarctions that evened out the treatment, the effect over time. And so the mechanism is there. So now we looked at revascularization and mortality. But what about contractile function? So this is a single center registry analysis. And they found that about 60% of patients that had a reduced ejection fraction and received bypass grafting actually had LV recovery, but 40% did not. Okay? So this is registry. Here comes the randomized data. So for Stitch here and for Revived, there has been no difference whatsoever by PCI or CABG on contractile function. So what does that mean? What does that mean for the other registry type? You know, if these patients are well medically treated before they are randomized, they are patients are taken care of well, they are well selected. In the routine patients, we operate on many patients. The same mechanism applies to mitral clip, by the way, in our mitral surgery as well. We treat these patients, we operate on them at a time where their optimal medical therapy has not been adjusted before, oftentimes, right? I believe that actually reduces surgical risk, but that's a different story. But so when we then send them home, they are then optimally medically treated, and when we come back 3 months later, who says that the treatment effect is due to surgery or due to mitral clip? It may just be due to the medical therapy, because that is impressive if you see a failing heart with the new medical therapy that is out there, the Fantastic Four. You know this. So, I mean, there is no impact of treatment of revascularization on contractile function. Okay? So let's re-examine our paradigm. We have treat symptoms, improve contractile function. No, does not. Prevents myocardial infarctions. CABG, yes, if the risk is high. PCI, well, maybe difficult, very small. And improve survival. CABG, definitely yes, because it reduces myocardial infarction. But PCI, probably not. If a left main infarction occurs, that patient is dead. So this patient has a survival impact with a stent as well, because the stent then provides protection against that infarction. That's how you explain these data. Okay, so is the paradigm accepted? I'm not sure. Are you all convinced that your thinking that we started in the beginning is correct? Are you willing to, and are you ready to rethink? Okay, so let's see again. If you have an event rate for cardiac events that is independent whether there's obstruction or no obstruction, all you need is plaque. That's a radiology paper, right? All you need is plaque in order to get a heart attack. You don't need an obstruction. So here's our new conception of coronary artery disease. You have this non-obstructive coronary artery disease that in some of the lucky ones, I would call them, they develop obstructive coronary artery disease. They develop symptoms. They may progress to myocardial infarction, and they may be in that small group of patients that actually get a heart attack from it, but the majority have symptoms. But the vast majority of patients come without symptoms, have a sudden infarct, and they have myocardial infarction, and that's this larger group. And so the only thing you can do, if you detect the symptoms here, and if you have this situation, you can put a graft on these and then take care of this problem as well. With this, you will not treat this problem here. Okay? So that is something that is new, and from that, I believe that the term revascularization does not appropriately describe the different mechanisms of invasive treatment, right? And I will show you in the last few minutes why we as surgeons should not use it anymore. Okay, so what are the consequences then? Well, I believe we need to assess risk and benefit. We need to tell patients what are the risks of surgery and what are the benefits. And then the patient can decide, right? So, you know this comparison of PCI and CABG here, right? So, we know that the benefit at 5 years is here, these 2%. You remember this, right? Do you remember the 30-day outcome? What's the 30-day mortality of PCI? We always go and say, oh, this is too dangerous to operate, we need to do PCI, okay? There's no difference. If the patient has the same risk profile in randomized trials, that is the case, there is no difference in 30-day mortality. So PCI is less invasive, yes. A patient is has to go through much more pain, more whatever, right? But it's not less dangerous. So either PCI is much more dangerous or cabbage is much less dangerous than expected. Okay, these are the facts. And we've done a systematic review all over the world where we found that long-term mortality was also, again, better with cabbage in the registries. But here, this is the registry data short-term for those that show it. And you can find situations where cabbage is better than PCI in 30 days and the other way around. And if you look at the mean here, there's almost the same, basically the same. So again, even in the registries, mortality is not different. You can say randomized is selection bias. So now comes the communication with the patient and why randomization and why revascularization as a treatment is a problem. So if you talk to your patient, you say, sir, you have triple vessel disease, and we need to revascularize you. And this is what many people do. And then we say there are two ways to do this. We have PCI, prick in the groin, or we have cabbage, and we need to cut you open, and that's it. So which one do you prefer? So what happens in this scenario? The patient assumes revascularization describes the mechanism of treatment. So the patient assumes that because cabbage or PCI are both called revascularization, they exploit the same mechanism. But in reality, that's not right. And of course he decides for PCI. Everybody in the room would probably go that way in this situation, right? But what if I said this? Sir, you have triple vessel disease. There are two invasive treatment options for you. One is less invasive, little prick in the groin, treats your symptoms, and that's it. And the other one is a much more invasive one. We have to cut you open, we have to cut everything, but it treats your symptoms, it reduces your risk of myocardial infarction, and you will probably live longer. In addition, the 30-day risk of dying is the same. So what do you prefer? So what do you prefer now? And that's why I say revascularization is the wrong term for a surgeon to use to describe what we do. And that's why I think don't revascularize. I say rethink and provide collaterals. And for those of you who have not sort of followed this and you like it maybe more in a poetic way, I have this, and I say thank you for your attention.
Thank you, Professor Torsten Doenst, for the wonderful oration. We invite the chairpersons to honor Professor Doenst with a memento and certificate of honorary membership.
Thank you, Professor Doenst. May I request Dr. Praveen Varma and Dr. Shivnair to please come on the dais. Ladies and gentlemen, it is my privilege and pleasure to announce that the Society of Coronary Surgeons India is pleased to confer honorary membership to Professor Torsten Doenst in recognition of his outstanding contribution in the field of coronary artery surgery. Signed this day, the 5th of April, 2025.
The conference organizing chairman, Dr. Shiv K. Nair, and organizing secretary, Dr. Praveen Varma, also take this opportunity to present a memento of appreciation and gratitude to Professor Doenst. The memento is the Aranmula Kannadi, meaning the Aranmula mirror. This is a handmade metal alloy, first surface mirror made in Aranmula, a small town in Pathanamthitta in the state of Kerala, India. The mirror is produced by one extended family in Aranmula. The exact metals used in this alloy are maintained as family secrets. The tradition goes back to many centuries and is considered a special gift for special occasions. The Aranmula Kannadi is polished to perfection and will last for eternity. Thank you all. And now it is time for session 8, Presidential Address. It is our honor to invite Dr. Chandrashekhar Padmanabhan to deliver the presidential address. The topic is In Pursuit of Excellence. We also invite Dr. Sanjit Peter to do the introduction of Dr. Chandrashekhar Padmanabhan.
Good evening, friends. It is my privilege to introduce the President of the Society of Coronary Surgeons, Dr. Chandrashekhar Padmanabhan. He is the Chief of the Division of Cardiothoracic Surgery and Director of Heart Failure and Transplantation at GKNM Hospital in Coimbatore, and every single person sitting in this audience today knows him and looks forward to the wonderful CMAs that is conducted at GKNM every year. Dr. Chandrashekhar did his fellowship in Adelaide and then went on to an advanced fellowship at the Mayo Clinic in the United States of America. He has been in Coimbatore since then, and it is my privilege, ladies and gentlemen, Dr. Chandrashekhar Padmanabhan.
Thank you, Dr. Sanjit Peter. And now over to Dr. Chandrashekhar Padmanabhan.
Good evening, ladies and gentlemen. You have been listening to a feast of academics, brainstorming, and lateral thinking from the previous speaker who delivered the first SCS oration. We were spellbound by the amount of work that he has done. Today I stand before you to deliver this presidential oration as the President of the Society of Coronary Surgeons, which is a very young society. I've titled my talk as Pursuit of Excellence, the Making of an Academic Surgeon, which is the core DNA on which this society has been started. SCS, as the logo indicates, surgery is science, and so we want to make it more scientific. It was a humble beginning when few of the surgeons on the side of the IICTS meeting decided that we should do some academic activity and present some data from our country. The PROMOTE trial was designed, and this was presented at the AATS by Dr. Lokeshwara and later published in the Indian Journal, the first randomized controlled trial comparing on-pump and off-pump surgery from our country. Few of others joined after this, and it consolidated. And then, on the 20th of December 2020, the SCS was formally inaugurated by the then Honorable Vice President of India, the Venkaiah Naidu. It was peak COVID time, so it was virtually done. We had the presence of Professor Angelini there, and Dr. Mario, and also the sitting president of the STS, Dr. Joe Direni, who was also instrumental in getting SCS collaborated with the STS for the database. The mission of the society is to enhance the ability of coronary surgeons to provide high-quality patient care through education, research, innovation, and advocacy. The vision is to improve the lives of patients effectively with coronary artery disease and surgical treatment. The goals of the SCS is to address this gap in the scientific data from our country, recognize the need for a systematic documentation, which is lacking in us, promote research methodologies, develop robust data registries, so that we can position ourselves the Indian coronary surgery on the global academic map. The membership was based on an annual subscription so that there is a commitment for the members. Admission was based on some academic credentials, and we encouraged the members to actively participate in academic activities. The participation of the STS database was initially mandatory, which has become optional. We also decided that the leadership of the society will be by consensus and credentials. Pursuit of excellence, if you look at the meaning of this word, you have several contextual explanations for this. Our former president, APJ Kalam, said excellence is a continuous process and not an accident. Doing ordinary things extraordinarily well was a quote by Gardner. Now, one thing that appealed to me most was by Charles Dickens in David Copperfield. He said, "My meaning simply is, whatever I have tried to do in my life, I have tried with all my heart to do well. That whatever I have devoted to myself to, I have devoted myself to completely. That in great aims and in small, I have always been thoroughly and earnest." Martin Luther King said, "Whatever you do, do to your best of your ability." That defines excellence. The most profound meaning for anything in excellence came from Swami Vivekananda, based on this book, which had a profound impact from my childhood. Every time I read this book, it gives me a different perception. This was based on the lecture Swami Vivekananda delivered in Los Angeles on the 4th of January 1900. It says that pay as much attention to the means of the work as to its end. The goal is always more enchanting than the means, but once you choose the goal, identify the means, then forget the goal, perfect the means, the effect is bound to come. Today you will have several management people talking about systems and processes. This is what basically is. The journey towards excellence begins with good mentorship, disciplined inquiry, and a continuous reflection, continuous audit of ourselves. The intent of this society is to foster excellence based on rigorous scientific inquiry, evidence-based practice, evidence from all of us, and collaborative innovation again from all of us, so that we build academic surgeons. What defines an academic surgeon is just not the technical mastery, but scientific rigor, intellectual curiosity, innovation, and knowledge dissemination. It's an intersection between cutting-edge research and compassionate patient care. There is a society in the United States called the Society of Academic Surgery. They give 7 attributes and they are called as physician scientists. But the key is innovation, dissemination, and training of the juniors who come. Now, there are 2 people who I have always held in great awe. The 2 people I have worked with, one was Hartzell Schaff, whom I worked with, and also I still keep in touch, and Jürgen Schäfers, with whom I have interacted over the last 12 years. They are not operators, but I found them great thinkers, innovators, and also a lifelong learners. I was once driving with Jürgen Schäfers from Homburg, where he works, to Brussels, to the aortic repair meeting, and then it was a 3-hour drive. And then we were discussing on a length of topics. I was amazed at the spectrum he had, not just cardiac surgery, and then the width and also the depth of knowledge. So I was inquisitive and I asked him, "How do you remember all these facts?" He said, "If I choose a subject, I go deep, and deeper till I think that I don't find anything else. And that's how I keep remembering and reinforcing what I have." So we should depart from what is called as a seolism or seoless. This is a word that I recently learned, which shows a superficial or a pretentious show of knowledge, often lacking depth and genuine understanding, which I accept myself in many areas I am. So the society's aim is to shift all of us from a seoless to an academic surgeon. Charles Mayo quoted that in order to be a teacher of medicine, the doctor should always be a student. This is a book many of you would have read, by Malcolm Gladwell, on the 10,000 hours. We find people who are outliers, who are very successful in life, but what he says is they work hard and harder than the rest of others so that they achieve this result. This was based on a research by Erickson. Now, he quotes 2 examples. One is based on the Beatles, you all know. The Beatles performed in Hamburg, Germany between 1960 and 1964. They did about 1,200 concerts and more than 10,000 hours of work. And they shifted to England the people found that they were new, fresh, and the music was astounding. And rest is history, you know, one of the most famous bands in the world has created. And this is based on the 10,000 hours of work. And he also goes on to say that just putting 10,000 hours doesn't matter. There is something called an opportunity and environment. The man on your left is Christopher Langan, who is supposed to have an IQ of about 200. But he was a bouncer in a bar and owned a Hans farm, whereas the man on your right, you know, was an IQ of 140, born in an affluent family in Manhattan, and he was the first person to do the atomic bomb, Oppenheimer. Now, this shows, so Malcolm Gladwell says it's a collective impact. No one, not rock stars, professionals or athletes, or even billionaires and geniuses, ever makes it alone. Success is a complex interplay of personal effort and external circumstances. We are all interconnected in this universe, and that is why, as a society, we can have a greater collective impact. Rafael Nadal said whenever he goes to practice, he goes to learn something new. So practice with passion. This is a man called C.K. Prahalad. Some of you would have known. He's called the management guru. His C stands for Coimbatore. He comes from my town. And then he defined the concept of core competence. He said every one of us have something in us which is special. He says, reflect on that, find what is your strength and develop that so that you become successful. Also, he says, assume responsibility for outcomes as well as the processes and people you work with. How you achieve your results will shape the kind of person you become. The coronary surgery today is evolving. We had a lot of discussion on whether multi-arterial grafting or grafting at all is good. Minimal access CABG is growing, hybrid techniques, endovascular harvesting of conduits, and recently robotic assisted surgery. Now, what I appeal to all the members here and the friends here, that we need some quality assurance at the end of coronary surgery. And that is very, very important. This is something every one of us can do. And transit time flow measurement is a simple tool to assure the quality of the grafts at the end of the operation. TTFM is a 2A recommendation in the ESC ACTS guideline in 2022 and is the only intraoperative quality control tool. Norman Chauvet, in his 8 years presidential address, said, certainly it cannot matter as much as who does the operation than how it is done. Now, we are in an era of artificial intelligence where it is going to impact our lives in a large way. And a lot of you will be already using some form of AI today. It can risk stratify, it can plan your surgery, it can provide real-time decision support, and also post-operative management algorithms, and also promote academic research. Academic research can grow in a huge way if we use AI effectively in literature review, data analysis, hypothesis generation, and manuscript writing. So we have to adapt to change. Einstein said, if you always do what you always did, you will always get what you always get. So with the AI coming in, I think we should empower ourselves to use this AI effectively because we have no way. We have to adopt it and adapt. Now, challenges facing Indian coronary surgery is the data scarcity and quality, both. We need involvement and participation. We need more training, mentorship, and guidelines. And funding for research is also a crucial point. So the role of SCS today is to build this ecosystem consisting of national registries, collaborative trials, and mentorship programs. And I think this is going to be the 3 areas where the SCS is going to focus and thrust upon. The SCS STS database was the initial. From the day it was the inception of the SCS, this was a requirement, and many of the members participated in that. The STS database, as you know, is the largest cardiac surgery database in the world with more than 10 million patient records. The adult surgery cardiac database has more than 8.3 million records, and they provide accurate predictive models. The STS database is constantly innovating and evolving, and recently they linked with the National Death Index. Now, this was published a couple of weeks ago. STS published the data on CABG for the year 2024, and something is interesting. 54% of cardiac surgeries was still CABG. The predicted risk of mortality was 1.7%. MAG resulted in reduction in mortality at 10 years, particularly patients with BMI more than 40, no benefit. MAG also registered an increase in the numbers, predominantly due to increased radial usage. There was a significant increase in minimal invasive cardiac surgery to 17.6% and robotic surgery by 22.2%. The number of centers doing mix and robotics in 2023 was 144, suddenly bounced to 658 centers in 2024. Mix showed a decreased trend towards MACE events, surprisingly at 30 days. Now, the SCS STS database is participated by about 23 surgical centers across India, and we have about 11,000 odd records so far, in which CABG we have 8,519 records based on off-pump and on-pump. The details of the database report is going to be presented to by the database manager Pavitra following my talk. Now, we have also submitted 2 research proposals to the STS, one on the use of arterial grafts in LV dysfunction. We had a lot of discussion. And also propensity match comparison of patients with left main disease, revascularization. So these are the study proposals from SCS we have submitted to the STS. Now, there has been STS database is very, very elaborate with 216 variables, which is very cumbersome to enter. So we thought we would create a database for the SCS, which will be basic parameters and which will be rolled out shortly. So I urge every member of the SCS to commit towards quality data at this basic. There will be 2 components, the basic SCS database, and if you want the advanced version, it will be the STS database. So this will help facilitate us move forward and position us on the international academic forum. The difference between excellence and mediocrity is the commitment, and we owe it to our patients. Mark Twain said, success is a journey, not a destination. It requires constant effort, which we need, and vigilance and re-evaluation. So, to the members in the fraternity here who are going to be members of the society, I make a clarion call for collective excellence. Thank you very much for your attention.
Thank you, Dr. Chandrashekhar Padmanabhan. We now move on to session 9, SCS database. We invite Ms. Pavitra Ramnath for database presentation.
Thank you, Dr. Chandrashekhar. May I request Dr. Lokeshwara Sajja, our founder president, Dr. Praveen, Dr. Shivnar to please come on stage as we present a memento to the president.
Good evening to one and all present here. I'm Pavitra. Thank you, sir, for the introduction. And before I start with the presentation, I would like to thank all the speakers from morning who have been discussing a lot on the different aspects of coronary surgery. But the one undercurrent that I could find was the urge for a database, urge for real-time evidence to prove a lot of your practices that you have been individually practicing at your institutions. So with that note, so the disclaimer is that all the data that is presented here is anonymous, was anonymized. We don't know which institute it came from, and we don't know which patient it belongs to. And they're all extracted from the STS ACSD database, and they are part of the harvest reports. So they are analyzed by the STS, and we are just presenting it over here. Some of the distributions are from the non-analyzed data because we would like to know and show you how many contributors have been for the past 4 years. So this is our STS database contributors. The hospital NPI, as I said, we have anonymized. People who are contributing will know how much they have contributed. As Sir had suggested, we had over 12,000 cases currently in the database. So we have a huge cohort that we can work on and real-time evidence from across the country. So the database actually categorizes surgeries under these categories, as we are aware. So whoever is interested in specific surgeries can access the data and analyze hypotheses accordingly. So we're going to focus today on isolated CABG and the outcomes, as this is a coronary conference. So the STS database is very extensive, as Dr. Chandrashekhar had mentioned. It covers around 216 variables. So it's probably more extensive than your IPK sheet. Every single thing is recorded in the database. And it comes under 16 different categories. And the numbers over here show the number of variables under each of these categories. We're just going to focus on some of the major ones today. So the first one being demographics, the basic one which we are very much interested, the age. Surprisingly, we find that the Indian cohort, we have a younger population, that is 63% of our coronary surgeries were performed among people who were under 65 years of age, while with SCS, it's only 38%. So I think morning Dr. Pradeep was presenting on long-term survival, and we should move to other studies. But now that the cohort is shifting to a younger population, I think it would be crucial to now do studies on long-term survival, because most of the STITCH and other landmark trials had the average age of 60 or 66. But now when you have a cohort of 40 to 50 years and you're going to do a survival of 20 years, that is going to mean a lot. And that's where research is to be headed. And with respect to gender, as expected, the male dominates the surgery and the people on the table. I think it's dominated by your gender on either side. And again, the male population, we're seeing younger population in male, 24% of them were less than 55%. Women, we still healthy till 65. So 9% of them are under 65, the rest of us are a lot elder. And the other variable that they're collecting is on race and ethnicity, which does help us. Being part of STS, we are able to compare the Indian, the Asian ethnicity with the rest of the world. Moving into the risk factors. So these are the major ones. We found, as expected, STS to have a higher percentage with most of the risk factors. But alarmingly, diabetes is more in our country. We have 64% of your patients with undergoing CABG to be diabetic. And these are the other risk factors that they cover. So there is the reason we have quoted all of the variables is to show the magnitude of the database and the possible hypothesis you could generate and the causal inferences you would like to infer from that. And with respect to hemodynamics, this is basically your echo report. The number of diseased vessels, again, dominated by the triple vessel disease, and EF of less than 40% is among the 21% of your patients. And moving into the operative data, so this was pretty surprising to see 98% of our surgeries are elective, while only 42% of the surgeries from the STS is elective. They're mostly emergency over there. So I'm pretty intrigued, and I was just discussing with Dr. Sanjit, why is there such a huge difference? 98 and 42 is pretty steep. And then I found this data as to see time to CABG post an infarct, and less than 7 days is more in the West, and we do only 37% of the cases we take under 7 days. And I probably think that is why we have a lot of articles from the West that wants to fix on when is the most appropriate time to take the patient to CABG post an MI. And they usually, the articles say within 24 hours and within 3 days and 7 days. And probably this is the reason why they want to target and find a cutoff point as to when to proceed for procedure. So we mostly take after 7 days, and even after 21 days, we have a 28% of patients opting for CABG. With respect to coronary bypass, so left main, 82%. The combined bilateral left main and right main is 17%, while it's only 7% from the STS. And radial, we've gone up to 31%. This was gradually increasing, and accumulated from year 2021 to 2025, it has climbed up to 31%. So again, another query that I was asking a couple of surgeons was, with the higher incidence of or high prevalence of diabetes in your patients, and I think I heard a lecture on DSWI, which with Lima and Rima being taken, they have a higher risk of developing a sternal infection. Is this something that we would like to study on to see, despite of taking a bilateral, our incidence of deep sternal wound infection is less, and that is what we've observed in the overall outcome, which is fairly less. And we don't want to dwell much on this because we have very few participating centers when compared to the SDS, as Sir had presented 4,300 surgeons from the West, and we are 23 surgeons. So the numbers are pretty low because we still have not gotten a good mix of surgeons entering the data into the database. So the way forward is what I would like to focus on today, is to create the SCS national database. We are contributing to the STS database, which is very vast, and we find it's very time consuming, and there's a lot of incompleteness in the data. So what we have proposed is for SCS to have their national database, which would be a basic version with around 50 to 60 variables, easy to enter. So we have more participation and more data inside real-time evidence, and we could start researching and probably create more cohorts from the real-time evidence and have long-term studies. We don't always have to do randomized control trials, but I think the research paradigm is shifting towards real-time data and creating cohorts. As end of the day, when a patient comes to you, you really cannot rely on an RCT because they probably will clearly fall in the exclusion criteria. So it's good to have real-time evidence, and that's where SCS would like to move in. So I request all the participants to start being part of this national database, so we could have some more literature and some more evidence for the future surgeons. And establishing cohorts, as I suggested, we are opening and welcoming proposals from all of you, which we would like to analyze and give it back to you, and you can take it up for publications or presentations at conferences, because this is a good large data set that we have, an extensive data set that we have, and we would like all of you to be part of it. So if you would like to have center specific or region specific analysis, we are more than happy to do the same, and we would help you with all of the analytics as well. So I'm going to stop my presentation here because I would like to hear from you. This is people who are interested can please scan this. It's a short survey. It hardly has 3 questions as to how many of you are actually willing to be part of a database if we were to create one, and what do you think will stop you from being part of such a registry or a database, and what would you actually expect from a database? Because I do understand most of you are academicians, and we are part of other registries, and one major bottleneck that I keep hearing from clinicians is that the data doesn't come back to us till the registry's purpose is solved, till they actually publish and use the registry's data. It does not come to you. Your data is given to someone else, and we are not able to retrieve it for the because till the registry comes out, they'll not be able to give the data back to you. But we would like to change that, and with this national database, we would like to provide access to all of you who are contributing, and you will have your own dashboards to see how your data is presented. You will also be able to visualize the entire national database summary, but you will not be able to visualize another surgeons. So the anonymity between the surgeons will be maintained. You can either see the entire database dashboard or your own private dashboard.
Thank you, Ms. Pavitra Ramnath. We now invite.
I think you have listened to this. Pavitra is the database manager for the SCS. She has been working with us for the last 6 months and has done tremendous work putting together and finding which are the centers which is actively participating and what are the missing variables. Because if your missing variables are more than 20%, the STS does not do a dashboard or harvest. So we are trying to tighten that so that we get some useful information about the data we presented. I think we have some time. So if there is any question anybody wants to ask Pavitra or to any of us, it will be welcome.
And this QR code is for those who are interested to be part of databases or to do
Please.
studies.
Chandrashekhar, I'm very sorry. If you remember, when you started this group, we had a talk, and I told you that if the same people of IACTS are here, why IACTS database is bad and yours will be the best? No, this I had told you, and you had rightly wished that after joining this association, the database will be perfect, 100%. So I'm not very happy that I've turned out to be true, but I'm really unhappy. I'm very sorry. I empathize with you. Madam, the same people in IACTS who don't give data are here. Only the label has changed from IACTS to Society of Coronary Surgeons. So same problem, same element which persists in IACTS persists here.
I agree with you, sir, but the thing is, that is why we are creating a basic database so that we can get some variables out of it.
IACTS data also is a very basic database.
I understand.
No name, no mortality, nothing. No risk factors, nothing.
Correct.
Just operation, age, sex, gender, that's all.
The thing is, participation is the key, and we are not participating. As a part of the IACTS database, we are the #1 center in the country, as you would know. GKNM Hospital, our center.
No.
Let me tell you. So I am dedicated to whatever database. Of course, the STS database is very, very extensive. If you want to do really some academic work, we need that sort of a database. So this is optional. If somebody wants to participate and produce some results, it's fine.
The one sentence which you said in your speech, that it was mandatory to provide data.
Correct.
If you want to become member. Now it has become optional. This one sentence, there are so many sentences hidden.
I agree with you.
In this one
That's
sentence.
because participation is very difficult to get people enter this data. It's a real problem. And that is a big gap. That is why we have come with the proposal of having a basic database, which will be minimal variables just for coronary surgery, not entire renal cardiac surgery, so that which we are trying to make it mandatory to all members of the SCS. Of course, this was discussed in the executive. We have to write to the members to do that. So this basic database will be made mandatory for all the SCS members, whereas the STS database will be as an advanced version. So whoever wants to participate, and any publications or any research methodologies or study proposals we are going to submit based on the STS the authorship will be for the people who participate in that. But for a society, for a country, like we need some basic data, like you said, how many memories. You are perfectly right in selling the same element will hit because participation and involvement. So we are going to make this basic database mandatory for all members.
Perfect. Thank you.
Thank you, sir.
Sir, I'm so sorry, but before you leave, you said you've been part of both, and okay, sorry, no, but you're.
See, one thing that will help, I think, is if we could get some training for, if we appoint people, then the society should form a training module, like I can send a PA or whatever, so that he gets the expertise in entering data. So that will definitely help.
Absolutely. We have actually emailed all the participants to, get their person who is entering. For me, my physician assistant is entering. So we, in fact, thought we will have a workshop here so that they can bring them, but it was not possible logistically. So we are going to conduct a series of webinars to train people
to how to enter so that the data quality is there, because we have a lot of missing data now. So completeness is the quick question. So we will be doing that as part of the training process.
And those who have not yet started entering, we will be inviting you soon, within the next month or so, with specific emails to all the members to become a part of this. The training process will start after that.
So I have a question, sir. So if I opt
Just
for
a Ritvik, only request again and again, like I addressed, is participation. Unless we have a collective impact, it won't be impactful. So we need a collective, at least, smaller group
I'm afraid we have to move on.
Yeah.
Because we have fallen behind schedule.
So if I have opted for the STS option, so I get automatically got SCS, yes. Or is the vice versa is true?
Both.
So if because my hospital is probably going to be enrolled for the STS, so I get automatically updated for the SCS also, is it?
See, the membership to the SCS gives you a direct access to the STS, which is a privilege actually, because it's, the society pays for the database.
Yeah.
So the basic database, we want to make it mandatory to every member. The advanced will be optional, that is the STS database, which will be more elaborate to present, publish, or develop research methodologies. You have the option to choose what. The basic one will be mandatory, the second one will be optional. Advanced version will be optional. That's what we plan to roll it out.
Thank you, Ms. Pavitra Ramnath.
Thank you all.
We now invite Dr. Lokeshwara Rao Sajja to deliver a talk on Promote, Predict, and What Next? Challenges in Conducting RCT. Good evening, everybody. At the outset, I would like to thank the organizers of the 4th annual conference of the Society of Coronary Surgeons for giving me the opportunity to talk to you on challenges in conducting RCTs in cardiac surgery. The randomized controlled trials are important tools in evaluating the effectiveness of medical interventions, including cardiac surgical interventions. In India, cardiac surgery is rapidly growing field due to the rising incidence of heart diseases, and RCTs are necessary to ensure that these surgical procedures are effective and safe for our practice, for our patients. The evidence supporting the surgical procedures has traditionally been based on observational studies. This paradigm remains true for the cardiac surgery, where a significant reduction in the number of randomized controlled trials has been seen over the last 2 decades. These are temporal trends in the number of published cardiac surgical studies and randomized controlled trials showing a significant reduction in the number of trials. Studies suggest that RCT's design can only apply to the 1/2 of the treatment questions in surgery. The successful completion of surgical RCTs is complicated by several factors, including differences in surgeons' preferences, operator expertise, limited funding, general education of the surgeons, and knowledge of clinical epidemiology in the surgical community. Although registry studies have an important role in reflecting real-world practice and patient heterogeneity, the randomized trials are the only approach to minimize bias and hidden confounders. The percentage of published trials comparing both devices and interventions, and many of them are in the interventional cardiology side, 78%, and only 27% on the surgery side,
In the interventional cardiology, most of the studies are related to devices, whereas the procedural studies are more common in the surgical practice. The percentage of industry-sponsored trials are more commonly conducted in interventional cardiology, whereas the investigator-initiated trials are more common in the surgical procedures. This temporal trends show that the number of total randomized trials versus the completed trials in both interventional cardiology and cardiac surgical trials, there is a definite gap between the total number of trials registered and total number of trials completed. Coming to the challenges that may be related to trial design, trial implementation, and also data analysis. For a trial design, it's important to establish equipoise. Equipoise is the situation where there is no clear-cut evidence that one intervention is superior or inferior to the other and is the prerequisite for the design and conduct of any clinical trial. Individual equipoise to the individual clinicians, whereas collective equipoise, the clinical equipoise, applies to the profession as a whole. It is expressed as guidelines or recommendations. The equipoise in surgical field is more complex than in the medical field. It is the key that equipoise exists not only among the surgeons, but also in the cardiology community and the patient community. The surgeon expertise is an important variable where the volume outcome association has been demonstrated for several procedures in cardiac surgery. Unless participating surgeon has the expertise in both the procedures, there is a potential for differential crossover due to the technical reasons, which has been shown to affect the outcome in the cardiac surgical RCTs. Eligibility and requirement for the surgeons based on the minimum volume of the specific procedure has been used for many trials. Choosing the right threshold may be challenging. If the threshold is too low, surgeons recruited into the study may not have enough experience or expertise to perform the procedure safely and correctly. And conversely, if the threshold is too high, it may be difficult to recruit enough investigators and external validation is jeopardized. There are several examples in published cardiac surgery data where divergent results among the trials have been explained by surgeons' eligibility requirement. For example, in the R2 trial, a higher than expected crossover for experimental to treatment group, that is 13.9%, with values for individual surgeons varying from 0% crossover to 100% crossover, which has likely influenced the outcomes. Defining the intervention and outcome is very important in a trial. A trial can only reliably address a single research question based on the primary outcome measure. Therefore, more effort should be made in defining the outcome. Defining the intervention and outcomes, ideally, the definition of intervention in cardiac RC should follow 3 steps. One is the clinical description of the intervention. The other one is detailed description should be provided, including the operative procedure and recommended technologies, a clear statement and justification of this, how it differs from the standard practice. Similarly, we have also mentioned all the details of the control procedure. The composite clinical endpoint is usually used to evaluate the treatments. Coming to the challenges in the trial implementation, funding. Funding is one of the key challenges to the success of any RCT. For surgical trials, obtaining adequate funding is particularly difficult. Recruitment and retention of the patient. The majority of the cardiac trials recruit slowly, which take longer time than expected, which may affect the outcomes and the results in early termination of the trial. The key factors are a priori establishment of clinical equipoise is the key to the trial's success. A second key factor is an effective screening process, and the third key factor is the engagement of the patients throughout the follow-up period. Coming to the challenges in the data analysis, issues with the data analysis is randomization allows comparability of the trial, and many factors such as crossover or withdrawal or loss to follow-up disrupt the randomization process. The form of non-compliance causes loss of statistical power for the trial. Statistical methodologies to mitigate the bias introduced by the crossover loss to follow-up include instrumental variable analysis, imputation techniques that account for the potentially different dropout across the study arms, marginal structural models, and other models to account for the informative censoring. The learning curve effect. During the learning for a new technique, the trial results may be affected by the degree of expertise acquired by the operator. And health economics and the cardiovascular surgical trials. RCTs offer an opportunity to capture data on resource consumption and measure of health outcomes, and this can be used to estimate cost effectiveness. The challenges in implementation of RCTs in our country, one of the major challenges in conducting RCTs in India is the lack of resources and infrastructure. Many hospitals and clinics may not have the necessary equipment or expertise to conduct high-quality randomized controlled trials. In addition, the cost of conducting such trials can be prohibitive, particularly for smaller institutions. Another challenge is the clinical consideration, ethical consideration of the conducting RCT in India. India has a diverse population, and it is important to ensure that the trials are conducted in an ethical manner that takes into account the cultural and social context of the participants. Despite the challenges, there is a strong need for RCTs in cardiac surgery in India because we have to generate evidence based outcomes of our patients. In order to address the challenges associated with implementing the RCTs in cardiac surgery, it is important to establish partnerships between researchers, healthcare providers, and also we have to utilize government agencies. These partnerships can help to provide necessary resources and expertise as well as to ensure that the trials are conducted in ethical and culturally sensitive manner. We have participated in ART trial, Roma trial, and STITCH trial, many of the centers in India, and the outcomes were published. Particularly, there are several participants from India in the coronary trial. And the arterial revascularization, we are also part of that. There are few centers from India which has published 10-year outcomes, and also the Roma trial, the main Roma trial, the enrollment is complete, and now we are going to the participating in the Roma woman trial, So there are so many centers participating in international trials that help us in conducting the randomized trial on Indian patients exclusively. In India, multi-center RCT in coronary surgery, we have published the conducted and published promote patency trial. The outcomes were presented at the AITS annual meeting and later on published in an Indian journal. And the PREDICT study, which is now funded by the governmental agency, ICMR, and now the enrollment of the PREDICT trial is complete, so the study is on. For the PROMOTE trial, we have published the 3 months outcomes, 1 year outcomes, and 5 year outcomes were published in the Asian Annals. And the PREDICT study, which is now undergoing, there are 17 centers participating in the trial, and the enrollment is complete by the 1st January 2025. Now the graft patency assessment is going on. We in India, we have also done single-center randomized trials, off-pump and on-pump, in non-dialysis dependent renal insufficiency between off-pump and on-pump, which was presented at the annual meeting of AITS in 2006, later on published in JTCVS. Similarly, there's another study conducted in post-operative outcomes by Narayana Hridayalaya, which was published in Indian Heart Journal. So this was a trial we published. So the future directions for the collaborative research to develop Indian guidelines. India is among the countries performing the highest number of cardiac surgical procedures globally, offering significant opportunity for impactful research. Systematic collection and analysis of our extensive data will benchmark Indian outcomes against global standards. Publishing high-quality studies in international high-impact journals is critical for showcasing Indian expertise. We have to increase multi-center collaboration for large-scale RCTs and prospective observational studies among the Indian cardiac surgeons. The collective data will guide the generation of evidence-based guidelines and optimizing the surgical strategies specifically for Indian population. To conclude, although a substantial amount of cardiac surgical work is performed in India, only limited publications are available. Indian research is frequently overlooked internationally due to lack of publication in high-impact journals. To increase the global recognition of our practice, it is crucial to prioritize outcome analysis and publications, particularly the publications from the randomized controlled trials. Thank you.
Thank you, Dr. Lokeshwara Rao Sajja. I'm afraid we do not have time for a formal break, and we are moving on to the inauguration ceremony. For this, we invite Dr. Chandrashekhar Padmanabhan, President of SCS, Dr. Sanjit Peter, Secretary of SCS, Founder, President of SCS, Dr. Lokeshwara Rao Sajja, the conference organizing team of Dr. Shiv K. Nair and Dr. Praveen Varma, Professor Torsten Doenst and Professor Gianni Angelini to the podium for the customary lighting of the ceremonial lamp.